This is Matthew Holt from the healthcare blog and Health 2.0. I'm in the canteen of Bupa, which is a large private insurance company in the UK, and I'm talking with Annabel Bentley, who is the medical director and runs the health informatics group at Bupa. I hope I got that right. Close enough. So Annabel, you've been to several Health 2.0 conferences in the US, and we're looking forward to seeing you as one of the speakers on the closing panel at Health 2.0 Europe. So give us a quick summation. What have you seen that's interested you about Health 2.0 so far?
Well, thank you very much for the invitation, Matthew. I think what's really interesting about Health 2.0 is how it has the potential to improve care for patients. It improves it in lots of ways. It helps people understand more about their condition, and more importantly, it helps them change their behaviour and make healthier choices. I think I've been following it because it's a huge wave of technological change. There's a huge step change happening. Now people can talk to each other in ways that have never been possible before. Through social networks, patients are talking about their care, about how to manage their cancer and what to do next. There are some really big opportunities.
So give me a word or two about what Bupa is doing and thinking about in terms of the kinds of tools you've seen.
I think Bupa's looking at lots of options. If you have a look at our website, you get a little bit of a flavour of what's going on. We've got everything from health risk assessment tools to information for our customers to more sophisticated tools such as decision aids. The key point is getting things that improve our patients' health. Great.
So I'm also here, and I'm going to flip the camera here, with Emma Stanton. Emma is a physician who has an incredibly long list of accomplishments, which the most interesting one may be that she's been on around the world yacht race, but has also worked with the Chief Medical Officer of the UK, and next year will be working as a, what kind of fellow in the US? Harness fellow in the US. And Emma is going to be on a panel at Health 2.0 talking, giving viewpoints about, specifically around hospitals and payers, but it's early days for you regarding the Health 2.0, it's the first time we met, but give me a little bit about what the work you've been doing in the UK and what kind of areas of research you've been focusing on.
A number of different areas. One of the areas that I'm particularly interested in is how we engage junior doctors and undergraduates in the healthcare debate. So I'm particularly interested in new ways of training doctors to think not just about how they treat the patient sitting in front of them, but to think about how they can be involved in contributing to the community and also to improving the quality of the service at a wider organisational level. And I think there's a really crucial role that improving lines of technology and communication between the doctor and the patient that can play, that can feed back into that sort of understanding.
Interesting, and you were just talking to me, Emma, before I started rolling the camera about the virtual ward, which is a couple of those are just starting up in PCTs, which those of you who do translations are primary care trusts, which is kind of like a mini staff model HMO in the UK. The UK is doing a fair amount of interesting things in terms of trying to change the way it organises primary care. Give us a sense about what's going on in those virtual wards and an idea about what kinds of tools are being used there.
Okay, well, one of the big debates that we have at the moment in the UK is how we can reduce or overcome some of the problems that we have between barriers between primary and secondary care. And if we're looking at improving the quality of care for patients, we want to start thinking about what we can do to prevent them coming into hospital, particularly when we're looking at models of chronic care. So one of the initiatives which is developed is called the virtual ward, which is a way of risk stratifying the population so that you can then identify those people who are not yet in need of admission but are very likely to within the next 30 days. And for those people who you think are at high risk of needing admission, you can put in additional resources by admitting them to a virtual ward. Now that doesn't mean that they change location, they're still at home or in the nursing home where they're based. And they either get a doctor or a nurse who comes to visit them or is in contact via email or telephone, doing everything they can to prevent their need to admission, in some cases giving them almost as much care as they would have in hospital, but they don't actually have the associated risks associated with going into hospital, the idea being they can avoid that.
Great, and we'll be seeing a couple of examples of that, probably not from the UK at the conference, but from a couple from Holland and one from Denmark. So there's a lot of interest in doing that, and there's obviously similar interest in the US. Great, well, I'll say thanks a lot to Emma and also to Annabel.
Thank you very much.
Two of the leading young, I probably shouldn't say that word, leading young MDs I've met in the UK, and I'm looking forward to seeing both of you in Paris.